As it says on the board, Associate Professor of Emergency Medicine and Pediatric Emergency Medicine. I'm both trained in pediatrics and emergency medicine. I'm also the medical director for our local fire department, and I sit on the ACEP program board. So I really like evaluations because that's what ACEP program board is all about, right? So there's this app thing that we're using today, apparently has an evaluation. Please use that. Be frank, be helpful. Don't put "this sucks." That doesn't help me, okay? What would help me, is some sort of critical evaluation. If you're a med student, can you raise your hand? Who do I have? All right, excellent. I like having all the med students because, I teach at the medical center, so, oh, come on. There we go. So apparently I need to go back. So we're talking about myths in medicine. Unfortunately, the med students will be shown lots of myths in medicine. You will hear it, you'll sit there and roll your eyes because you know it's not true, but unfortunately we keep teaching it. So what is mythology? It's oral initially, then it's written down. In medicine, it's almost all this, somebody told me that, and now I somehow know that. And it keeps getting passed on and passed on and passed on, and they're not true. There's this power relations. You got gods, men, father, son, mythos, abstract to logos, and then even the first physician, the Asclepios, is a mythological son of Apollo. So the same thing occurs in medicine. We have this communal need to have like rules, like things that you can't do, right? We're told that, hey, you can never do that. Well, why can't you do that? I've been told many things like that, and then I ask, and nobody can give me the firm answer. So I'm going to go through a couple, right? So one of the first ones, and I'm sure many people have already understood this and learned that this is actually not true. Analgesia should be withheld in acute abdominal pain pending assessment. I can tell you in medical school, the University of Kansas, Kansas City, they told me this specifically, that you cannot give morphine to somebody with abdominal pain because it will ruin your exam. That is absolutely not true. That's been shown to not be true, and I'm going to show you how that is. But in Cope's early diagnosis of acute abdomen, that's where that started. This person right here heard it from somebody, put it down in a book without anything to back it up, and it's been going on ever since. Come on. All right. There's 1997, there's a bunch of papers, and then I'm going to go through this guy here in Journal Emergency Medicine, 2004. They use morphine versus normal saline, or normal saline versus morphine, before and after evaluated by the surgeon and the emergency physician, each documenting the presence or absence of the 6 physical signs. Morphine median decreased the pain, 20, 0 mm's with the placebo. Essentially, there was no change. That's the main focus here. There was no change in the 6 physical findings: rebound, right lower quadrant tenderness, guarding, referred pain, cough pain, or position pain. So really, morphine helps the patient feel better. Give the patient something for pain. You will not obscure the physical diagnosis. Now, if you give him enough that he stops breathing, yes, you're going to obscure the physical diagnosis. You probably went too far, right? I'm a big believer in special ketamine. Ketamine's a great drug, but you can't go far enough so that they can't answer you, because then you've obscured it. So don't go that far. Here's another one from Pediatrics, a great journal. Administration of morphine did not reduce the diagnostic confidence of either emergency physicians or surgeons. And then it goes on to a bunch of numbers, which you can just look at. I did upload these to the app thing, so if you want to go through them at your own pace. Okay, so bottom line, there is good evidence that the early ED use of IV morphine reduces acute abdominal pain without obscuring the diagnosis or changing the treatment. That's my final on that one. Okay, cephalosporins cannot be used safely in penicillin allergic patients. There is cross-reactivity. We all understand that a first-generation cephalosporin was produced from penicillin organisms. So there is some from it, but does it actually give us that cross-reactivity that we can't do? So there's 2 families of antibiotics which were feared when the first cephalosporins were created because of that similar structure. The incidence of allergic reactions to cephalosporins and penicillin allergic by history patients has been reported to be 8 to 15%. This is a big one because it's by history. I'm sure many of you have had the occasion where the patient says, my mother told me I'm allergic to penicillin. I don't know what to do with that. I mean, what's your reaction? How do I know that you're truly allergic? Did you ever get penicillin? And if you investigate it, the few times that I actually had the mom with me, the mom was allergic to penicillin, so therefore the child must be allergic. That's not true, okay? So don't go with that. More reactions are skin manifestations. Anaphylaxis due to cephalosporin exposure is very rare. First generation cephalosporins have more chance of cross-reactivity with penicillin than do the advanced third or fourth generations. That makes sense, right? First generations, like I said, were produced because they were like your penicillin. The cross-reactivity between penicillins and second or third generation cephalosporins is probably higher than the cross-reactivity between cephalosporins and other classes of. All right, so cephalosporins can be used safely in penicillin allergic patients. I would tell you, ask, what was their reaction? Okay, so with a history of penicillin, have a threefold greater risk of a subsequent reaction to any medication, not just cephalosporin. So that, I'm not really sure we can even say that it's due to the cephalosporin, but you know, you have to understand, they had a bad reaction, they had anaphylaxis, they had intubation, ICU care, God help me, a trach or something. That's bad. I'd probably stay away from that. But you want to say, okay, well, what reaction did you have? If a physician is contemplating using, giving a cephalosporin to a patient with a penicillin allergy, the nature of the allergy should be attained, which is what I was just talking about. So all these guys, allergy groups, Joint Council, all that stuff, 50% of patients with a history of allergy to penicillin will have a positive skin test, and of those, 98% will tolerate a cephalosporin. 98%. So even the ones that they skin tested for penicillin, with only 15% having a history of it and all that kind of stuff, 98% will still tolerate a cephalosporin. So you are very well and safe to give a cephalosporin. If you're in doubt, do second, third, fourth generation cephalosporins. And that way you don't knock off a whole class of drugs and then the patient can't take anything else. So cephalosporins can be used safely in penicillin allergic patients. Many patients with a reported history of penicillin allergy are not truly allergic, and cephalosporins can be used safely in the vast majority of patients who report a penicillin allergy. Epinephrine. This is one that has always gotten me, you know, and it still makes my sphincter tighten if I'm going to place epinephrine into a digit, okay? But it actually has been shown that that can be done. So this belief has been taught based on the rationale that epinephrine causes vasoconstriction via the alpha receptors in the digit, N-terminal. You can get arteries leading to ischemia and gangrene. So in Denkler's review of the world's literature for the past 120 years, he could only document 48 cases of digital necrosis from local anesthetics. None of those involved the use of lidocaine. 21 entailed the use of epinephrine, and the majority occurred 50 years ago when everybody was diluting their own epinephrine, right? So now we get those preloaded syringes, or you get one that already tells you it's 1%, 2%, that kind of thing. Well, apparently 50 years ago, when probably most of us weren't practicing, certainly, 50 years ago, you had to dilute your own. Well, I can understand that. You may be making a mistake, because in pediatrics, we certainly make compounding mistakes of percentage-wise, right? So that may have been the cause. But even with that, he could only find a few cases of that. And then in Chronick's 2004 literature review, he only found 50 of digital gangrene after local anesthesia. 21 of these used epinephrine. The concentration was reported in only 4 of them. So we're not even actually sure what concentration they used. And then careful analysis, 21 reports failed to show that epinephrine by itself was the cause of the necrosis. Okay, so epinephrine is safe for digital anesthesia. 1998, Salatis and Logan prospective study on digital arterial perfusion after performing digital blocks with 2% lidocaine, so that's with a 1 to 80,000 concentration of epinephrine. They only found a transient reduction in blood flow. Finger perfusion was maintained without the development of digital ischemia or gangrene in any of the 100 consecutive cases. And then in 2001, these folks here did a prospective randomized double-blind study to evaluate the role, compared 1% lidocaine versus lidocaine alone. Digital blocks were performed using the dorsal approach. They got hemostasis with a tourniquet. Essentially, we'll move to the red. No complications were reported in the epinephrine group. And now these authors actually now routinely use lidocaine with epinephrine for digital blocks in their institution. So don't be concerned about using epinephrine. Judicious use of epinephrine in digital anesthesia can prolong the length of anesthesia, because that's really what we want. We want to make it last long enough so we can fix this thing or bring that finger back in place or whatever it is that we need to do. It decreases the bleeding, of course, and has not been shown to result in any significant complication. Okay, positive troponin and renal failure. So this occurs, unfortunately, quite frequently. You know, you get the person, he comes in, he's complaining of chest pain, he came from dialysis center with chest pain, you get a troponin, it's positive. Well, why is it positive? Can we really rely on that? The problem comes down in elimination. So we're always eliminating troponin, right? Troponin is not an absolute, if it is, you are therefore having a heart attack. It's at a level because there's always some cell turnover. The problem is the people with dialysis or on dialysis, kidney failure, are not able to clear that, and therefore their troponin just appears to be higher than what we would expect for a normal person. Stably elevated troponin concentrations are commonly observed, so they usually have somewhat of an elevation. The cause of low troponin elevations in this is likely chronic myocardial injury or underlying structural heart disease. They're getting these massive, you can think of it as a massive transfusion every time they go to dialysis. There's a lot of stress on their heart, so there's going to be some breakdown of the troponin. The CNT or I, so troponin T or troponin I, used providing serial concentrations are followed rather than single values. The degree of elevation in the T or I is required for the diagnosis of AMI and CKD patients. So a greater than 20% change in serially measured troponins is probably an acceptable threshold change. So this is really hard because you only had them for that first hour, right? You saw them, they had the chest pain, you got your troponin, it's elevated. You need to make a decision now. Should I call the cardiologist? Should I not? Let's get a delta troponin. Let's see what's going to happen in the next hour or two. Let's see if they're still continuing a rise. All right, so that don't rely solely on one troponin to say that that person is having a heart attack. Say, okay, I'm going to get a serial troponin. I'm going to get the delta troponin in 2 hours, and then I'm going to have to make a decision. If it's continuing to rise, it's a done deal. You can certainly start considering him for a heart attack. You don't have to say that that is absolutely what's going on. All right, this one you've probably read about, tap water versus sterile water for irrigation. I think we like to use sterile stuff because it really looks good. You know, you pop on your gloves and use your sterile water. It looks good to the family, but honestly, it doesn't really matter. You could use any water. There's been talk about, should I let the faucet run, you know, like 30 seconds before I do it? If your tap is that dirty, yeah, you should probably let it run 30 seconds. But I don't know. I wonder often about, you know, the hospitals. I mean, got to be the worst place, right? I mean, we got stuff there all the time. I tell my med students never touch that microscope that we look at the wet preps and all that with bare hands, because then they would have to explain to their significant other how they got that, okay? Don't touch anything. But your tap water is just as good as your sterile water for irrigating wounds. And then I have a quick one here. Equivalent rates of wound infection were found using either, again, 715 subjects were enrolled. 4% of the 300 subjects in the tap water group had wound infections. 3.3% had wound infections in the saline group. The relative risk is there, 1.21, with a confidence interval of 95%. Confidence intervals are good, right? We want confidence intervals. For those of us who have no idea what statistics mean, confidence intervals are good. That's what I learned in statistics. Confidence intervals are good. Okay, Sterile gloves, again, that show, hey, let me go put on my sterile gloves because, again, it looks really good, and I get out my nice blue towels, and I tell the parent, don't touch this because, I'm keeping everything nice and clean. Meanwhile, the kid's thrashing around, the towels fall off, and I have to put them back, and the suture has already gone through the kid's hair or whatever. I'm not actually keeping anything sterile, but it looked really good when I started. This is actually the book. I was the clerkship director for our medical students. I think I stopped 5 years ago. So that is the book that I had them use in our program. And it said, I pulled it out just to get this thing. On page 751, it says, get out your sterile gloves in order to do suturing. So that didn't make any difference. Prospective multi-center trial, 816 individuals. No statistically significant difference in the incidence of infection between the two groups. So you could use the blue gloves or whatever color you got on the wall versus the sterile gloves. Now, we all have some value to using the sterile gloves because it fits my hands much better, right? I got little hands. I usually use a medium and I kind of have some extra on it, but if I grab a 7 gloves, it fits me really nice. So if I'm going to suture something, I might get the sterile gloves only because it makes my hands, fit better. But don't look at it as I'm keeping this sterile because that's not actually true. Or at least it's not actually giving you anything. CT before transfer of suspected pediatric appendicitis. So this one is one that, at least when I work in the Children's Hospital of Georgia, the emergency department there, this is one I come up with all the time. For us, I have my pediatric surgeons there. But many of you don't work in a place that has a pediatric surgeon, and what are you going to do? Should I get this guy a CT scan? I mean, we're trying to decrease the amount of CT scans in children, right? We don't want them to glow in the dark by the time they're adults. So we want to decrease the amount of radiation. Should I do it? Should I not do it? It's really kind of a difficult thing because you probably want to consider transferring, but you don't want to call the surgeon up and say, well, he's got pain, but I don't know, he could not have it. Most actually, ped surgeons would actually want you to transfer rather than irradiating these people, and I'm going to go through that in a moment. So for children who have atypical or equivocal findings for appendicitis on physical examination and laboratory testings, imaging may be helpful to establish or exclude the diagnosis. Imaging may also be needed for patients who have received antibiotics prior to evaluation. We really like ultrasounds now. We're going towards ultrasounds for the right lower quadrant pain. And CT is coming on separately or in combination, modalities used most. So if you have an experienced person who can do the ultrasound for you, this is where it comes into play. You need an experienced person for a child ultrasound and the reading of it. I would tell you, go for the ultrasound, okay? And the same thing goes with the CAT scan. If you have an experienced person who can read your CAT scan for you, because it's not me, and it's probably not most of us, we don't really want to read those CT scans, go for the CT scan prior to transfer to assure yourself. But most of us don't have that luxury. We don't have somebody who's really experienced. We might even be using these Nighthawk people or something like that, which may or may not have the experience. So I would tell you, emphasize examination, all right? Think of it as a pathway. There are many places that have actual pathways, but think of it as a pathway. Examination. If you're sitting there walking away from that room going, geez, he's probably got it, you need to call up your surgeon, your tertiary center and say, I want to transfer this person. I'm really concerned. The surgeons are not going to turn it away. At least certainly not our surgeons. They're very good about saying, yeah, go ahead and transfer them. We'll put them on peds. We'll do re-examinations and check them before we decide. So I would tell you, be more apt to say, I want to transfer this person and have someone else evaluate them. Okay, so early transfer to a pediatric center prior to imaging is advocated. So this is from Surgical Research, 2017, volume 216. CT imaging performed at a community hospital has a 44% higher radiation rate relative to the exposure at pediatric centers. The reasoning for that is the size and the complexity of your CT scan. So we tend to use the small, thin slice CT scans. They give short distances. They got all sorts of ones. We now work with Philips mostly, so they've changed all the amount of radiations. That may not be true in all of your settings. So consider what you got. I would expect that here at Memorial, not that I've ever worked there, or Candler for that matter, I think they could probably do stuff like that. They have fairly decent equipment. If anybody knows differently, they can let me know. But I would say early transfer, talk to your pediatric surgeon, talk to your pediatrician, whoever it is that you can transfer to before you decide to irradiate the child. Come on. Shaving of the eyebrows. I actually was never taught this, that shaving of the eyebrows for suturing was a bad thing. Seems kind of excessive, unless you got some really massive eyebrows, do you really need to shave them to do that? But if the laceration is through the eyebrow itself, you could consider shaving them down. Eyebrows, so this is the Natalie actually says this in the textbook that she's the, chairperson of. Eyebrows should not be clipped or shaved routinely because their delicate contour and form are valuable landmarks for the reapproximation of the wound edges. It is also unlikely that they will grow back in exactly the same fashion as they had been before the injury. Diagnosis and treatment of surgery, eyebrows should never be shaven, and then the Fleischer-Ludwig, which is the pediatric textbook for emergency medicine, 7th edition, 2016, advisable not to shave the eyebrow for wound preparation as it serves a landmark for the repair. Alopecia of the brow will result. Well, apparently that's not true. So there's no single article that supports the common teaching that the eyebrow shaving was occasionally associated with failure of regeneration. There's a lot of women who go and have their eyebrows done, and yet it still keeps coming back, right? Because they keep going back to have their eyebrows done. So that can't be true. If not, we wouldn't have these places where you go and have that done. Appropriate reasons for not shaving the eyebrows. Eyebrow hairs do grow slower than the other body hair, so it is going to take a while for it to come back, so it's going to look kind of weird for a while. There's a cosmetic and aesthetic issues associated with prolonged period of eyebrow regeneration. Might be a little weird, disconcerting for the patient itself. Removal of the hair prior to the surgical repair of the wound involving the eyebrow may remove important landmarks. So I actually don't shave them ever, only because I like to see that it lines up real well, okay? This is a landmark, okay? This is right up there with your tattoo, right? If you have a laceration through a tattoo, you suture the tattoo first, right? You bring that together because that's what he's going to complain about. Not the fact that he's got a really big old scar on his arm now. No, the tattoo's not lining up, so that's what he's going to complain about. It's the same thing going on here. Try and line that up first prior to anything else. So in the end, don't worry about if you have to cut them back a little bit. They're going to regrow. Corneal abrasions should not be discharged home with topical anesthetic agents. I had that little bottle of the tetracaine, most people probably have that when you pull it out of the Pyxis. I don't, the nurse pulls it out because thank God I don't have access to the Pyxis. I don't want that. They give me that little bottle, I set it next to the patient, I give him a couple drops, and then I come back in 5 minutes to look at his eye, and sometimes that little bottle isn't there anymore. The patient, I guess, has thrown it in his pocket because he makes it feel so better. Is that a problem with a corneal abrasion? Well, the application of the topical anesthetics decreases the corneal sensitivity, so the patient may have a worsening abrasion without knowing it. I guess that's true. Application causes direct toxicity. This one, actually, people have told me that it'll burn through your eye if you use that often enough. Apparently, that's not true either. The evidence of harm comes from case reports and case series. The two largest, 1968 and 1970, all right? So a lot of us weren't around, some of us were. 1968, 1970. New England Journal of Medicine, they reported 5 cases of patients who developed keratitis after topical anesthetic use. Canadian Journal of Ophthalmology, the patients all developed corneal complications after prolonged, inappropriately frequent topical anesthetic. So these are very, very old studies. So what is it that we actually think now? What is the truth on this, or at least at the moment truth? So you can discharge them. So here's a big old study from Ball, 33 patients randomized and received this, either diluted, placebo drops. Anyways, we'll skip all that down to the red. Pain scores improved in proparacaine group, but and no patients of either group had any ocular complications. And then here's another one. Waldman represents the largest, best quality study. 116 of them patients were instructed to use the drops every 30 minutes as needed for 24 hours. The study excluded a number of groups, including those with contact lenses and those presenting for more than 36 hours after injury. But the essential end of it is they didn't find any difference in the abrasion healing between the two groups. All right, so it is reasonable to give patients with simple corneal abrasions, right, not contact ones, all right? Those are usually a little bit more extreme. Simple corneal abrasions and no contact lenses, 24-hour supply, which is that little bottle, of a dilute topical anesthetic. So they recommended 1/10 of the standard concentration. So you can simply put your little bottle, you can add in some saline to it, you're all done, okay? You want to bring down the concentration, they'll get some relief with it, they'll be able to go home with it, because really we don't keep those little bottles, right? I mean, we don't have to throw it out, it's a single use anyways. And that way they'll go home with at least something for pain and not have to call you back in 30 minutes. Many of these folks have a lot of pain and they end up using too many narcotics, and we really need to decrease our use of narcotics to begin with. So here's a simple way to do this. Try and dilute it. You'll find that that's probably a good thing. So that's my references for there. I am right on the time there. So I have the talk right after this. So either fortunate or unfortunate for you, whatever, I do two back to back. So if you want to get up, give me a big stretch or a wave or something, we'll get started on the next one in like 3 minutes, okay? Question in the back?